and welcome to my channel. If you're new to this channel, please do subscribe to it and press the bell icon so that you are continuously updated every time I upload a new academic content. So this time I'm going to take up preventive medicine, obstetrics, pediatrics and geriatrics. As you all are aware, this is one of the very important topics that we deal in community medicine, and you need to know it with a lot of clarity. Well, pregnancy is all about nurturing a home with you. Yes, indeed. But 5 women in India die every minute during childbirth. And this is despite the fact that maternal death has considerably gone down in the recent years. If the improved scenario is still this, that is why probably we need to know it all the better. A mother and child is often considered as one unit. Ever since the antenatal period, this journey continues. The healthy mother is able to give birth to a healthy child. If the mother is infected with any of the torch infections or other infections, there is every probability that the unborn child is also going to be affected. Besides, the child is dependent on the mother for the social, mental, and of course, the feeding, and all kinds of development. The postpartum care and neonatal care and family planning all are actually interlinked services. And it's needless to say that, of course, the mother is the first teacher of the child. So the bond is very strong. And it is time that we move on from fragmented personal health care in this regard to integrated family welfare services. And with this change of concept, there has been some terms that has met to the surface which you need to be aware of. One of them is the community obstetrics. It is the integration of obstetrics with primary health care. And then is the social obstetrics, which is the interplay of social, environmental, and the reproductive process. The preventive pediatrics is also an interlinked subject where the care of the children from the conception till adolescence is dealt about. And it may be of antenatal and postnatal pediatrics. Regarding the social pediatrics, it is about the child health in relation to the community, the social values, the policy, because they have a bearing on the overall growth and development. Let's look at the maternity cycle. The maternity cycle begins with the fertilization, the ovum and the sperm fusing together to form the zygote. And there the journey begins. Into the antenatal period, the 0 to 14 days period is called the ovum. 14 days to 9 weeks is called the embryo. And from 9th week to birth, it is called the fetus. Then is the antenatal period, the period during which the labor takes place, followed by the postnatal period and the interconceptional period, that is the period between two conceptions. As per the latest report of 2016-18 of Sample Registration System, that is SRS, released by the Registrar General of India, the maternal mortality ratio of India has declined to 113 from 122 in 15-17 and 113 in 2014-16. So, as I was also telling you earlier that yes, there has been decline in the maternal mortality rate. But notwithstanding, this maternal and child health comes across a major issue, as this segment of population comprises 71.4% of the population in all developing countries. And in India, It is nearly 57.5%. And half of the deaths are occurring among the children in the first 5 years. The vulnerable spatial risk group, because in the childbearing age group, the maternal mortality ranges from 13 to 440 per 100,000 live births globally. So the growth, development, and survival are crucial issues in this regard. The health of mothers and children has to be integrated through primary healthcare approach. If you look at the developed and developing countries scenario, you'll find there is a distinct difference in the maternal and child health. If the developed country is dealing with perinatal problems, congenital malformations, genetic and behavioral problems, the developing countries like us are more facing the problems of reducing the maternal and child morbidity and mortality because of the nutritional problems, communicable diseases, and many more. And if we look at our country, the maternal and child health problem triad comprises of malnutrition, infection, and uncontrolled reproduction. So let's look in detail. This malnutrition in women, particularly pregnant women, comes across as an iceberg phenomenon, because most of them remain undiagnosed, untreated, and the service unasked for. And this malnutrition has several adverse effects, causing low birth weight, anemia in the long run, precipitation of toxemia pregnancy, increased risk of postpartum hemorrhage. And this malnutrition can affect the birth weight, as we said just now. And this low birth weight is also related to the child mortality in the long run, because birth weight and child mortality has an inverse relation. Lower the birth rate, higher the chance of the child mortality. Weaning initiation period is also got to do something with this malnutrition, because often the weaning is not done properly and exclusive breastfeeding is also not followed properly. Here in this connection, the interventions can be direct by addressing the mother, and indirect by making the health infrastructural changes and the community awareness level being increased and making it proper. Coming to the second triad point, there is infection. It has its adverse effect, causing fetal growth retardation, low birth weight, embryopathy, abortion, puerperal sepsis. Women suffering from TORCH and UTI is quite a common picture, with 25% of the rural women presenting with this. In children, diarrhea, respiratory tract infections, skin infections, along with malaria and tuberculosis, which are almost endemic in our country. And there may be recurrent infections and leading to protein energy malnutrition and anemia in the long run. And as I said, the interventions can be direct, that is addressing the patient concerned, and cultural, because unless you make the family, the community understand the importance of this intervention or at the earliest, it is impossible to deal with this. Immunization of the vaccine preventable diseases, education in the right direction, sanitation and personal hygiene comes across as major weapons in this regard. The third one is about addressing the uncontrolled reproduction, which actually our country is presently suffering from. This unregulated fertility is causing increased low birth weight, and when the parity is increasing, there is severe anemia, abortion, antepartum hemorrhage, increased maternal and perinatal mortality, particularly after the fourth order of pregnancy. The family life education in schools is very important in this regard. There has been advent of some newer contraceptive methods which needs to be promoted The role of field workers is also very important in managing this particular segment, that is uncontrolled reproduction, because they can counsel the family, the couple, so that they are able to take a informed decision. And social marketing for the contraceptive devices are also one of the important methods to address this. Door delivery of contraceptives, cafeteria approach, where a plenty of different choices are given, the pros and cons are explained, what suits whom is explained, and then the couple, based on the information served and the different choices given, takes their own choice. And in this manner, the method adopted is the gather approach. What is the gather approach? Here G stands for the greeting, A for asking what are their requirements, T is for telling, that is what are the different choices, H is for helping, that is helping them with the whole scenario, E is for explaining each of them, and R is for return referral. The maternal child health actually encompasses a lot many aspects. The maternal health, the child health, the family welfare, the school health, addressing the handicapped children, as well as the adolescents. The basic objectives remains the reduction of maternal and perinatal, infant and childhood mortality, as well as morbidity. The promotion of reproductive health, promotion of physical and psychological health, development of child and adolescent within the family, and overall a lifelong health. Coming to the very first component of maternal and child health care, that is antenatal care. It is meant for promoting, protecting, and maintaining the health of the mother during the pregnancy. It is aimed at detecting the high-risk cases, foresee the complications, and prevent them, as well as remove the anxiety that builds around this pregnancy, reduce the maternal and infant mortality and morbidity, teach mother elements of child care and nutrition, sensitize the mother regarding family planning, attend to the under fives accompanying the mother, so that a holistic approach is adopted. In the antenatal visits, it is very important from your point of view that you know that when the mother is supposed to make the visits, because this is an often asked questions in your viva as well as part of your question in the theory. So basically once every month till 28 weeks, once every 2 weeks till 36 weeks, and once every week till labor. But if you look at this, it comes to quite a number of visits. And the rural women coming from remote villages who often don't have their healthcare delivery centers nearby them, it is not possible to lose their wage, affect their family running, cooking, or feeding, maybe if they have under 5 child, and making so many visits. So it is suggested they make at least, that is minimum 4 visits. So when are these 4 visits ideally recommended? That is, the first antenatal care visit should be as early as possible in pregnancy, preferably in the first trimester. The second visit between 14 and 26 weeks, and the third visit between 28 and 34 weeks, with the fourth visit being between 36 weeks and term. Whenever you are posted as a medical officer in a PHC or a sub-center, it is very important that you know that how many beneficiaries in the pregnant women sector you're going to cater to, because based on that, you're going to indent a lot of stuff, the vaccines, that is tetanus toxoids, the medicines, that is iron and folic acids, and make an estimation. Hence, to ensure the adequate stock, as I mentioned, and registration and identifying the missing numbers who are not coming for their care. The number of expected pregnancy per year, for that, you first calculate the expected number of live birth. Let's take it as capital A. So it is the number, it is the birth rate per 1,000 population multiplied by the area population. And the correction factor is 10%. That is 10%. B is 10% of A. And the total number of live birth is total number of expected pregnancy is A plus B. Why this extra 10% apart from the birth rate? Because the stillbirth are also here taken into consideration. Let's look at the preventive services for mother which are provided during the antenatal care. Of course, it begins with the history. You have to ask, check records, followed by the physical examination where you need to look, listen, feel, go through everything, along with screening and laboratory tests as needed, and treat accordingly. The preventive measures include ensuring immunization of the mother, adequate nutrition, so the dietary changes has to be suggested, family planning, and many more. The health education is also a very important aspect where self-care in parenthood, and if necessary referral services, and the couple also has to be informed regarding the different programmatic help they may get from JSY, JSSK or PMMSY. Regarding the lab investigation, the subcenter level, the pregnancy detection, hemoglobin estimation, urine for albumin, sugar, rapid malaria test, these are all carried out. At the PACCAC and first referral unit level, the blood grouping and typing, along with other ones mentioned in subcenter, VDRL, HIV testing, rapid malaria, blood sugar, H-based antigen for hepatitis B are also carried out. In this regard, one of the approaches adopted is the risk approach. What is it? It is basically a managerial strategy. Risk approach is also important for you to keep in mind because this is also important from your exam point of view. So it's basically a managerial strategy to improve the coverage and quality of maternal and child health and family planning services based on the measurement of individual and community risk. The main purpose of the antenatal care is identifying the high-risk cases among the large antenatal population, and at the earliest possible, these high-risk cases to be provided skilled care, while the routine appropriate care is provided to all the remaining pregnant population. So who are the high-risk pregnancies? Those who are suffering from severe anemia, that is, having hemoglobin less than 7 grams per deciliter, pregnancy-induced hypertension, preeclampsia, preeclamptic toxemia, having syphilis or HIV positive, gestational diabetes mellitus, hypothyroidism, young primary, that is less than 20 years of age, or elderly gravida, where she is more than 35 years of age, twin or multiple pregnancies, haramnios, short-statured primary, when the height of the mother is less than 140 centimeters. Malpresentation, previous LCS, low-lying placenta, placenta previa, positive bad obstetric history, that is history of stillbirth, abortion, congenital malformation, obstructed labor, premature birth. If the mother is Rh negative, patient with a history of any current systemic illnesses or past history of illnesses. Besides, any woman presenting with any of these warning signs are also to be immediately referred. What are these? These are having fever more than 38.5 degrees Celsius for more than 24 hours, headache, blurring of vision, generalized swelling of the body and puffiness of face, palpitation, easy fatigability, and breathlessness at rest, pain in abdomen of sudden onset, vaginal bleeding, watery discharge per vagina, reduced fetal movement. One of the important things I would like to emphasize here is the IFR regime to be given to the mothers. Why I'm stressing on this? Because there has been change in the IFR regime within, which is mentioned in your textbooks. And you need to remember this. There is daily 1 iron and folic acid tablets starting from the 4th month of pregnancy. That is the second trimester, continued throughout the pregnancy. That is minimum of 180 days during pregnancy. And to be continued for 180 days postpartum, each tablet having 60 milligram of elemental iron, which is a departure of the previous 100 milligram elemental iron. But the folic acid content remains the same, that is 500 microgram. And all these tablets are sugar coated and usually red in color. So what are the priority action for strengthening the antenatal care? It is about improving the quality of the antenatal care services by continuation of in-service and pre-service training for antenatal care providers, include the essential components and new competencies required to improve supplies and logistics, develop linkages with other programs, especially traditionally vertical interventions such as malaria and HIV, so that a holistic management is possible, harmonize the activities through effective partnership at all cross-cutting issues with involvement of stakeholders in all arena. Reduce the barriers to accessing care and reach out to women not accessing care. Make better use of data to monitor and improve the antenatal care coverage and the quality as well. Because if there is better quality, definitely the beneficiaries are going to come forth. Thank you so much. This is the part 1 of the preventive medicine in obstetrics, pediatrics, and geriatrics. We will continue the rest part in 2 more parts, which I'll be shortly uploading for you all. Stay tuned. Do like, comment, share, and subscribe. I'm again re-emphasizing, it's completely free. It's only meant for the benefit of all students and those who love public health. Thank you so much.